Hi, I'm Dr. Kearney, and this is Dr. Patel. We're going to be guiding you through this talk tonight, and thanks so much for taking time out of your evening or day, if you're listening later on the webinar, to tune in, and hopefully we have some good educational discussion today, and we all learn some stuff. So I was going to start by just kind of clarifying what Dr. Patel and I do. It's confusing nowadays. There's so many subspecialties in medicine. And what is exactly primary care sports medicine, which is our specialty? Why are we the ones giving this talk about tendon problems and this newer treatment called Tenex? So I was going to let Dr. Patel kind of explain what our specialty is and what do we do every day so that you can kind of get to know us better.
So our specialty of sports medicine in the primary care, basically we do non-operative treatments for orthopedic issues. We, do non-surgical things for musculoskeletal issues in the various areas of the body. Nowadays, orthopedics do specialize per body part. So I think in general, we in a whole can kind of treat various body parts with different, musculoskeletal issues. So, day to day, that's a lot of what I do. And then I also do a lot of fracture management, take care of, patients that have pain related to osteoarthritis, sports injuries of, various ages. And so in addition to doing ultrasound guided procedures such as the Tenex, like we're going to talk about today, as well as doing ultrasound guided injections.
Great, yeah, and our practices are fairly similar. We have slightly different demographics, I guess. We practice at different clinics, but yeah, to a large degree I do the same things. And I always like to say that most patients have no idea what we do until they need that care delivered. And just like our subspecialized surgeons should be really good at doing their surgeries every day, we should be really good at optimizing the non-surgical care. And would you agree that most of what comes in our orthopedic clinic's office is non-surgical, at least initially in management?
Yes, absolutely.
And so that part should always be optimized as well. And then we're the first ones to make appropriate referrals when we say, hey, no, this is something that our surgeon should really take care of. So that's kind of our specialty. And in my practice, about half my practice is ultrasound guided procedures, and I think that's the same with her. So we get a lot of experience with using that, and we're going to talk more about what that is and why that's important with the Tenex procedure coming up. So first off, the title of the talk involves tendons. So what is a tendon? To kind of keep it simple, I always say it's kind of like the puppet string that moves the bone. And muscles are attached onto bone with a thicker fibrous structure called tendon. It's a thicker rubbery structure that unfortunately has a poor blood supply and doesn't heal well with injury, unlike muscle, which has a rich blood supply and does heal well with injury. And hence a lot of the problems that develop with tendons, either acutely or over time, they just have a much harder time healing. Moving on here with my analogy. The other way to think of tendons is that they are like rubber bands. And just like a rubber band is nice and stretchy when it comes out of the package, as the years go by, it's a little bit of a crude analogy, but I think it's pretty accurate. Most of these chronic tendon injuries that we're dealing with are like this dry rotted rubber band that you see there on the right-hand side of the screen, where it just doesn't have the same elastic quality. It breaks down. You get little micro tears and frays, and it just doesn't behave the same way as it did when it was 20 years old. So I think that's a pretty good analogy for thinking about the tendon pain you might be having if you're over 50, especially. In younger people, it tends to be more acute problems, and a lot of them get better. But as we go through the birthdays, the tendon just doesn't behave the same. And I'll turn it over to Dr. Patel to explain more about that.
So just to kind of reiterate, tendonitis is definitely more of the acute phase where the tendon gets, inflamed or irritated. Tendinopathy is more kind of that chronic, degenerative tendon, such as Dr. Kearney was just describing. But anyone at any age can get either one of those problems. Tendinopathy is definitely more common with advancing age. This is, due because as the muscles get stiffer as we age, the tendon isn't able to kind of absorb the tension or the forces that we're kind of putting on them with our repetitive motions or just chronic overuse. So that tendon's not able to repair as well. And then it's also important to diagnose correctly. That way you can, prescribe the correct treatment that is needed. So that's definitely very important. I think of tendonitis and tendinopathy as more of a clinical diagnosis. So what that means is, your history as well as my exam, we can come up with that diagnosis of tendonitis, tendinopathy. It is not something that an MRI is necessarily needed. So that's kind of an important point to, bring up, that, it is more of a clinical diagnosis.
Do you sometimes get MRIs?
I will at times if, the diagnosis is uncertain, or I'm worried about something else, or we're trying to rule out something differently.
Right. Kind of case by case. So,
yes. Yeah. And so in general, tendonitis, the acute phase of, tendon inflammation, will get better with time. So, most of these, I would say 90+% of them do get better if you give it some time. Otherwise, tendinopathy, as it starts to go into more chronic, so now we're talking more like, few months of pain, etc. Those tend to maybe not heal as quickly, and those symptoms may come and go.
Do you have any timeline that you generally tell patients is more tendonitis versus tendinopathy?
Tendonitis, I definitely, in my mind, kind of keep it, under maybe 3 months, and then anything beyond that, kind of diagnose that more as a chronic, tendinopathy.
Me too.
Same with you? Yeah.
All right.
All right, so treatment options for, both of these. So, first thing is just kind of giving it the time for your body to heal, and allow that tendon to heal. So like I said previously, tendinitises in general will heal on their own. Tendinopathy will probably heal on their own, but those can sometimes take several months, and so I know that's hard to kind of wait that time out for some people. But other things, relative rest, activity modifications, so doing things that you're not aggravating that tendon to kind of give it the time it needs to rest. Other options, physical therapy, especially, eccentric exercises. So that's, exercises that help elongate the muscle. Studies have shown that that type of exercises do benefit tendonitis, tendinopathies. And then ice, NSAIDs, those are all used for kind of symptom relief. They're not really doing anything specific for that tendon to heal it per se.
You actually want the inflammation to heal it, right?
Correct, yeah. And NSAIDs are definitely, can be used for tendonitis in the acute phase, but not very beneficial once you've gone into kind of a chronic, tendinopathy, because at that phase there is no inflammation. And then counterforce braces or straps, a lot of times we, will recommend that with like a tennis elbow. That just helps to kind of relieve pressure, takes the forces off that tendon to kind of help let it rest. And then biologics like PRP, platelet-rich plasma. That is something that, can help with tendinopathies. However, it's not something that is, covered by insurance. So, that is a cash-paying, service or procedure. Other options are stem cell therapy. Again, insurances do not cover that. So that's something that, is a cash-paying. And also actually hasn't been shown to be very beneficial for tendinopathies. And then lastly, cortisone injections. Again, so that is something that can be done for pain control, so to help the symptoms, but it is not helping, the tendon actually do much healing itself. So definitely good in the short term, may not be super beneficial in the long term, and there's definitely side effects to consider or risk if you do multiple injections for cortisone.
And in your practice, Dr. Patel, would you say kind of 1 or 2 cortisone injections is pretty standard depending on the case before you move on to other things?
Yeah, that's definitely kind of my practice, kind of 2 at the most. If I can try to avoid more than that, right. I like to.
And I think that's where the trend in all the literature is going to, that we've proven cortisone is really bad for tendons, but a lot of times we still give it to cover up pain while the body heals. So it's not that
Correct.
The cortisone heals it, it's the cortisone covers up the pain while the body heals itself, and it heals despite the cortisone, not probably
right.
because of the cortisone.
Correct.
And that kind of brings us to our next slide. This is what tendinopathy looks like under a microscope. And I'll often tell patients that tendinopathy to a large degree is fingers or pockets of scar tissue. And the white in this slide happens to be the scar tissue, the pink is a healthy tendon. And that's what we're really dealing with. And I think at least 80% of most chronic tendinitises or tendinopathies will heal on their own within a year. So a year can be a really long time to wait, but if you're willing to wait and do the other things, we always encourage you to do that. Mm-hmm. But at some point, there's a fair number of patients that are recalcitrant to that, and they aren't going to get better. And at that point, it's just a bad tissue issue that the tendon hasn't been able to repair itself. And that's what it looks like under a microscope. And that's where more advanced therapeutics like ultrasound-guided percutaneous tenotomy, or what's called the Tenex procedure, come into play, and we're actually able to target that bad tissue and do something about it to improve it. That brings us to what is Tenex exactly, and that's what we're going to spend the rest of the talk on. So how would you explain what is Tenex? How do you explain that to patients who come to you for it?
So how I explain it is I tell them it's a minimally invasive procedure that we can do under local anesthetic. And basically, we're using a probe that has, a needle point at the end of it. And, that needle point basically allows us to, or it delivers, ultrasonic waves or energy that allows us to break up that chronic damaged tendon tissue. And then there's, a saline flush at the end of that as well, which we'll go a little more into, that allows removal of that tissue.
Perfect. And for a little bit more technical answer to kind of describe what this is in my hand, the needle point she's referring to is here. Inside that is another little needle point that goes back and forth about 25,000 times per second. And that has some mechanical effect on the tendon to kind of break it down, the bad tendon, but also the sound waves emit. And I always tell patients that it's like somebody hits the right note in a movie and the glass shatters because it's made out of different substances than the surrounding concrete, and the concrete doesn't shatter. So in this case, the glass is a bad tendon, the concrete's a good tendon. So it's fairly foolproof. It's only going to shatter the bad tendon because it's made out of different building blocks and different collagen fibers and different collagen types than good tendon is. And then it simultaneously kind of power washes the tendon with high flow saline, and then it vacuums out that whole soup of bad tendon and saline. And that's probably half the benefit, is just removing the bad tissue. I think half the benefit is causing a local controlled injury where you get bleeding and healing in the tissue, and then it goes through the healing phase. So that's a little bit more the technical answer. That when patients really want to know, I go into my dissertation there on that. And then Dr. Patel is going to talk about some of the common conditions it's used on.
So you can see from this slide here that there are lots of people that do develop tendonitis and tendinopathies through various parts of their body. You can see this slide says over 24 million patients per year get some form of, tendonitis and tendinopathies, and that's quite a bit. So if you kind of break it down, per body part, you can see the elbow is the most common with 7 million patients per year. And that would entail, tennis elbow, which is pain kind of on the outer side of the elbow, and then golfer's elbow, which is pain on the inner side of the elbow there. And then second common is Achilles tendinopathy, followed by, hip. So in terms of the hip, it's the glute muscles, there's the buttock muscles kind of wrap around to the outer part of the hip and attach on the bone there. Patients will get some tendonitis in that area or tendinopathy in that area to those glute muscles. And so that is definitely another common area, as well as the shoulder in terms of, rotator cuff issues from, overuse or calcific deposits in the rotator cuff tendon. So the calcific deposits happen kind of over time when patients get overuse of the tendons of their rotator cuff. In that wear and tear, some people will kind of build up some calcium from that overuse or just wear and tear, and that calcium deposit in that tendon becomes very painful for them. And then a couple of the other areas or plantar fascia, patients will get some plantar fasciitis along their heel, and the knee as well is another area as well with, jumper's knee or patellar tendonitis as well.
And just while we're on this slide, I wanted to get your thoughts. The rotator cuff specifically is kind of an interesting area. Mm-hmm. It's kind of a unique area of anatomy. And this was originally intended for the more basic tennis elbow surface level tendons that we could get to. But there's more and more research being done on like the rotator cuff. Currently, do you use it a lot in the shoulder, or do you reserve it mainly for calcific tendonitis or when patients don't have another good answer from another treating orthopedic doctor?
So currently I've been doing it mainly for the calcific deposits in the rotator cuff itself in my practice.
Yeah.
Okay. I think it just, rotator cuff tendonitis, tendinopathies is pretty common diagnosis for sure. But right now I've been using it for mainly calcific.
Yeah. Okay.
Same for you? Or?
Same for me. There's a few instances out there. I know rotator cuff disease is so common, it comes in a lot of flavors. So I don't want to mislead anybody that this is a magic tool for every rotator cuff problem. And there's lots of indications for traditional surgeries with it. But when there might not be a big tear, when you might not be a good candidate for surgery if your surgeon has told you that, I think there's select instances where it doesn't have to be calcific tendonitis, but I'd say maybe only 5% of the shoulder pain that I see every day might even be a candidate for Tenex. It doesn't seem to be
It's not a lot.
Not a lot unless it's that calcific tendonitis. So,
yes.
Okay, so that's both of our experiences with that, but it works great for calcific tendonitis. So here we go.
In terms of Tenex and using it for tendinopathies, Tenex was started back in 2012. Since then, we have used it to treat over 100,000 patients. And this graph here kind of breaks down per body part, what we have treated using the Tenex procedure. And you can see the two common ones are the elbow for tennis and golfer's elbow, along with plantar fasciitis or foot, pain. And then Achilles tendinopathy, as well as, the shoulder again. Again, I reserve that mainly for more of the calcific, tendonitis type stuff. But definitely, common in your, patients that are, may have do a lot of overuse work using their shoulder, like overhead stuff, or your athletes that may do a lot of overhead throwing, things of that nature. And then the hip, I would say the hip I do quite a bit in terms of targeting the gluteal tendonitis part on the outer part of the hip there. I think when Tenex first came out, I don't think it was meant to treat hip tendinopathies, but I think it's just revolved over time that we have found that it does help some. And so I do quite a bit of that in my clinic as well, or see patients with that in my clinic.
Yeah, and I think our understanding of that lateral hip pain has changed through the years, and what's always been called trochanteric bursitis or a lot of iliotibial band problems ends up being this gluteal tendinopathy. And it can be a very tricky problem to treat, as I think we can both attest to. We'll probably talk more about that, but it's a much more common problem than I think people have been told
Right.
or advertised, but also one of the more difficult problems to treat with anything if it becomes chronic. So now I guess it's my turn again. This is some of the clinical evidence with the trials that have been done, and there's a few slides later talking more about the clinical evidence. I always tell patients that studies are studies and clinical practice is clinical practice. They don't always mirror each other. You've got to remember that studies are kind of in an ideal world. You can rule in or rule out patients based on lots of variables. And most studies that are done, you try to optimize kind of the perfect situation. And this does show excellent clinical evidence that this works. And it's very encouraging to think that over 85% of patients will get pain relief within weeks of treatment after this. And for the most part, that's pretty true. I mean, I'd say over 80% of all comers do very well when you combine all the conditions we treat. But it all depends on how you define pain relief. And so you have to have realistic expectations. Not everybody's walking around 100% pain-free at 2 weeks. And most of these studies, when it comes to treating chronic tendon disorders that are by definition chronic, the bar's been set pretty low. And we define pain relief as a standard in most of these studies as greater than 50% improvement in symptoms. And we do get many, many people 90%, 99% better, 100% better. But there are some that are only 60% better, 70% better. But the really good thing about this technology, and I think you'll agree, is I've never made anybody worse long term, at least I don't believe we have. And it's about one of the safest treatments you can have done in terms of the downside or the risk. And for the most part, I say for the elbows, we have good evidence showing that it works well. I would say it mirrors the studies. I mean, probably 90% of the patients do very well with that. Plantar fascia, these studies look very promising. In real life, it can sometimes be more challenging than that. Patellar tendonitis in the right patients does very well. That's for the knee. The Achilles can be a mixed bag. I think the studies might be a little overly rosy for that one. There's several subtypes of the Achilles problems, and they can be really hard to treat, hence the term somebody's Achilles heel. It's always been hard to treat, but this has been a big step forward for a lot of those folks. And then we'll probably talk more about the hip, but good clinical trials have been done, and the evidence keeps growing each year that this goes by. And that's what we're going to kind of talk about. So there's the trials and studies that say this works, and a lot of them are very, very well done studies. But then there's also real life. So in your practice, which conditions does this really seem to work the best on?
I would say definitely elbows in terms of, tennis elbow and, golfer's elbow for sure is on the top of the list.
I would agree.
Sure.
And then I think right up there would be that calcific tendonitis in the shoulder, that if there was something, a condition designed for this treatment, I think that's the one because it's such focal pathology and you can get right to it. Is it hard to determine who's going to do well and who's not when you have a patient walk in the door?
It definitely can be because sometimes other factors play into it. And so it could be a multifactorial problem that you kind of have to make sure you weed through that and make sure you're picking the right patient for the procedure itself. So, yes.
And I would agree. And that's as a clinician who does this, it's one of the more frustrating things about it is, you can look at a fracture and kind of predict on the x-ray how that's going to do, or even is somebody a good candidate for a knee replacement or hip replacement. There are certain factors that we can all agree make that patient be a better candidate. With these tendon problems, it can be very hit or miss, it feels like, and the traditional markers of good patient or bad patient don't necessarily apply. And the people who really study this in depth have a hard time figuring out why that is, but I think we all have very different biology in terms of how we try to heal these tendon injuries. And it's just the traditional things like MRI findings, or how long you've had it, or how bad the disease looks, how symptomatic you are, just don't seem to be as predictable as a lot of other problems that we treat. And some of my worst patients on paper do the best, and some of my young, healthy people with one little problem struggle the most in terms of recovery.
Yes.
And it's kind of a head scratcher. I think everybody who does this that I talk to around the country agrees with that it's just, it's one of the more frustrating things about treating tendon problems is we can't predict up front who's going to do really well and who might not. So I talk in generalities most of the time and just say, in all comers with this problem, you have X% chance of getting better. The one thing I found, and I think we talked before, you agree with too, if you're really able to put a finger on it, like tennis elbow is a great example, like it hurts right here. Or for like the patellar tendon in the knee, it hurts in one finger breadth of a spot. Those are the patients that we know there's going to be very focal, bad tissue that this probe is really designed to treat. It's not designed to treat the entire tendon necessarily, although we'll do that sometimes if needed. That seems to be the one variable that I think we've agreed on that people do the best. So if you can really put your finger on that one spot, that seems to be a good predictor. And then I'm going to be quiet while Dr. Patel goes through some more information here on what the actual procedure looks like.
So if you look at the image there on the left, you can see the provider that's performing the Tenex procedure is using an ultrasound machine, and that's what provides the imaging for us to identify, the diseased tendon tissue. And the the ultrasound is also helpful because that's how we can watch our microtip of that Tenex and kind of get it in the right area that we need to treat that tendon. So on the right, we've got a few slides that are showing, ultrasound images. The very first one there, you can see that the area that's, the arrow is going to is the diseased tendon tissue. So you can see that tendon looks a little darker compared to the rest of that tendon, which looks more white, gray, kind of more uniform. So that's the area that we would, target for the Tenex procedure. The second slide there shows, the micro tip or the needle point of that Tenex probe going down towards that damaged tendon tissue, and it is showing that's going to be the area that we treat. So the Tenex procedure itself, when we do it and use that probe, we use a foot pedal to activate that micro tip. And once we activate that micro tip, that's what then starts the process of cutting the tendon and removing that damaged tendon tissue. So that's what the third slide is demonstrating there. So to start with, we clean the area with alcohol and everything is done under sterile conditions. And the first thing we do is, inject lidocaine into the area for, a local anesthetic. So that's how we numb that area up. And then secondly, once the area is numbed up, we place a small incision there. It's very small, but it's just big enough for the microtip of the Tenex probe to fit through that incision there. And then we're able to place the microtip of that tendon right to the area that we want to treat. And that's what's being demonstrated there on that bottom video there. And we clean that tendon up with back and forth motions of that microtip there. And typically, like for an elbow, it would take maybe 2 or 3 minutes to kind of clean that area up of us going back and forth. But how long we do it is basically based on us looking at the ultrasound and seeing that we have cleaned up all that damaged tendon tissue. So that's how we base how long we do it for. So this is just showing some areas that we treat again. So The one on the left is talking about treating the hypoechoic region. So that's kind of how we, describe what a, damaged tendon tissue looks like. And you can see that, the needle point going through that area. And then the one on the right is showing the needle point going directly into that calcific deposit like we had talked about with rotator cuff pathology. And it's great because you can target that needle point right to that calcific lesion and, break that up. And so it's another great, treatment for calcific tendonitis too, because it shows up very well on the ultrasound.
Yeah, and in the hands of somebody who does a lot of this and does a lot of ultrasound guidance, you're able to see diseased tendon really very well. And I know when the average person looks at a black and white image, it's like kind of looking at the clouds and like, oh, what are you talking about? But when you're looking at this stuff every day, there's a lot of training that goes into that and additional training, skills work, where certain signs of bad tissue. And I think we probably both kind of treat the entire area of where the tissue could possibly be bad, but then we spend a lot more time focusing on those very specific changes that we know are signs of tendon damage as well. And the calcific lesion on the right is a perfect example. I think that's one of the reasons this does so well for that, is that you can see it. There's no better modality that you can see it with, even at the time of open surgery or arthroscopic surgery. They're kind of going in blindly, hoping that they're getting that tissue. You can't see inside the tendon. With ultrasound, again, in the hands of somebody who does a lot of this, most of these body parts you can see with very good detail exactly where the tendon problem is. There's a few exceptions, like the hip is one where you just kind of treat the whole area, but based on where the tendon typically breaks down, you spend more time. But that's what I think we love about these calcific lesions. They do so great because you can really see them. They really jump out at you. And then you go home like this. So
yes. So lastly, the incision is a very small incision, does not require any, suturing or anything of that sort. And, we put some steri strips on there, and you just give it time to heal.
And we usually do a waterproof bandage so that you can take a shower and not have to worry about getting it infected or anything. That comes off in 5 days. Easy to deal with. So this is a video here. We can talk about it all you want, but sometimes schematics and animation's better. They're putting the probe in to that small incision. The white probe on the left is our ultrasound probe that we can see this tissue through. And then this is what the probe is doing in the tendon. You've got your 18 gauge needle equivalent going back and forth, creating sound wave energy. That's breaking down the tissue, high flow saline, and then suction to pull it all out. And that is showing you how only the bad necrotic tissue will come out. This is generally very cost effective. Both of us have primary care backgrounds, and God knows we can't afford our healthcare system. 20 cents on every dollar we make in America is spent on healthcare. And so one of the things we really like about this is that it kind of wins at multiple levels. It's quick, it's easy, it's well tolerated, it's safe, we're not causing harm. So very cost effective. There's no restrictions before the procedure. Total procedure time is quick. It's outpatient. We do it in a hospital, but you're typically there 2 to 3 hours and in the room itself for 30 to 45 minutes. There's little pain or discomfort during the procedure, so it's really more like an injection at first. You feel the poke and burn, and then it goes numb. If people are really nervous about procedures, I'll prescribe some medicine to take that kind of just calms your nerves a bit. You go home afterwards. There's no physical therapy, believe it or not. I'd say in 90% of the cases, sometimes we'll decide to send somebody to therapy if they're not progressing how we want them to, or if they have a lot of functional weakness. It follow up from being in pain for so long. And then the post-procedure course is really easy. It's basically an ice pack and Tylenol, no heavy lifting, but you can go back to lifting 5 or 10 pounds right away. And sorry for the spouses out there. They can actually do the dishes and do housework almost immediately, so they don't get a timeout from that. And then return to full activities. Typically, I say 6 to 8 weeks. 4 weeks is probably on the optimistic side.
I agree.
Except for the shoulder, you can go back fast with that. So, and I think I'm still going here. For those of you that are interested, we dig into the details of the studies when we're talking to other physicians and medical students and residents, but this is just kind of a 30,000-foot view of the studies. One thing I'll note is that a lot of good studies are being done more recently. 2019 had 6 of the better studies out there. This company only became profitable a few years ago, and unfortunately they have to be profitable before they can fund studies and they can really market it. So that's why a lot of people have never even heard of this. But we've been doing it. I think I trained on it 10 years ago, and then insurance started covering it about 5 years ago in mass. And now more and more people are hearing about it and having it recommended by their therapists or their other physicians or their primary care doctors. So the evidence is definitely building. There's actually very good studies on it now for most of these body parts. Insurance always lags a little bit behind in terms of what they view a procedure like and how they reimburse it and whether or not they'll cover it. Most major carriers are covering this, including Medicare, almost all the access plans. There's just a few of the big carriers that sometimes give us pushback on it, but it's still relatively cheap, even if you need to do it cash pay compared to a lot of other things. So that's just kind of a summary of the studies. Tennis elbow has been the most studied model since that's the most common chronic tendonitis in our bodies. I liked this graph because it is pretty illustrative of how most of these tendons behave after this treatment. In fact, in this study, I think the average duration of symptoms was actually closer to a year, so people with real chronic disease. And on a pain scale of 1 to 10, the average patient's pain was 5.5 before they underwent the procedure. And you'll see that blue line down there. It just kind of tracks down slowly. In reality, this is an average of everybody. So there's a bunch of people out of the gates who do great, and within 2 weeks they're pain-free. That's just from removing that bad tissue. Then there's a whole nother wave of patients that take 6 or 8 weeks to get better. As the tissue just heals, it heals stronger and better. They feel better around 6 or 8 weeks. And then there's even some stragglers that take 3 or 4 months to feel better. And then of course there's always the people that just, this isn't going to be the thing that works. Not in this study, 20 out of 20 it worked. But in real life, there's always a few that just don't get better and we have to move on to other things. That red line is probably even more important than the blue line. The blue line is just pain. The red line is what we call more functional scores. Can you do what you want to do? Are you playing golf? Are you able to do the chores around the house? Are you saying no to things? So you want a low symptom score, and so the lower the score, the better. And you'll see that improves pretty quickly. And even after a month, people are basically twice as good at getting back to life as before. And this extrapolates pretty well to the other body parts that we treat. I think we see the same types of curves with almost any body part we treat. And then I was going to let Dr. Patel kind of wrap it up here. So what if you thought you don't want to do Tenex? We don't like these people talking to us today. What else are we supposed to do? What are the other options? So I gave her the hard slide.
So. We mentioned before just, time itself, giving the tendon some time to heal, so you can just, wait further and see if time will help heal that tendon. At the same time, while you're doing some activity modifications, so trying to avoid the things that really aggravate that tendon. Again, cortisone injections can be done to kind of help that symptom, relief while the tendon is healing. Just have to be careful again of how many of those you're doing. Like we mentioned before, try not to do more than 2 in a specific area. And then we talked about, other things such as like, PRP, the platelet-rich plasma. Again, that does work fairly well for tendinopathies, but it is a cash-paying, service, so that's something that the insurances doesn't cover. We do try to kind of refrain from doing surgery if we can, but it is another option.
And some people end up needing it. I mean,
yeah.
some cases, just end up going down that road, but usually not the first choice, right?
Correct, yeah. It can be done on various tendons. We had showed kind of the diagram of the various body parts that it's good for. The common areas are, again, the elbow, the ankle for Achilles, the hip for gluteal, tendonitis, plantar fasciitis, things of that nature. So it's not done on, it can't be done on every tendon, but there are definitely, quite a few that it can be done for. And not in the hand itself, it's not meant for that.
Unfortunately,
Yeah.
There's no code for it. And I would have a tough time even doing it. Those tendons are so small, they're prone to rupture. And there's not really any real indications for it in the hand currently. Now that might change, 5 years from now, but nobody that I know of really across the country is doing it on the hand. So. There's always a risk of that with any tendon procedure that you do more harm than good. There have been a few case studies and cases reported specifically on the Achilles across the country of the tendon rupturing after this procedure. But that's less than a handful of cases in the literature and reported back to the company out of hundreds of thousands at this point. With the Achilles, it's a tendon that's prone to rupturing anyway. And it could easily rupture before you get to the point of surgery. We see a lot of people come into clinic with ruptured Achilles tendon. So when an Achilles tendon is misbehaving and big and swollen and painful, it can rupture on its own. And then when we remove some extra tissue, if somebody takes a misstep out of their boot, it could rupture, and that has been reported. The only downside of that is that you would buy yourself the bigger surgery that you're hoping to avoid in the first place. So there are salvage procedures for those things if it happens. And I have not had anybody else rupture a tendon. I've never had anybody rupture a tendon, but the Achilles is the one we worry the most about. If we both do 10,000 of these cases, eventually we probably will have somebody rupture the tendon. Some of the patients, we actually try to release the tendon off the bone, and that's a kind of game time decision when we're treating it. And for example, tennis elbow, there are some tendons that if they're ruptured in our body, it's a big deal, like the Achilles. There are other tendons where there's redundancy, and tennis elbow is one of those. If you have the tendon rupture off the bone, there's other muscles that do the same thing, and the pain goes away because it's no longer under tension typically, and you don't lose any functional strength. So sometimes we actually, and I've done that a few times, try to get the tendon to rupture off the bone. The plantar fascia, you actually try to get that one cord a lot of times to come off the bone completely as well in a case-by-case situation. But I wouldn't worry about that as a patient. It's not a major complication or a common complication.
From my experience, no.
Yeah.
I'll have kind of that younger person that you think is going to do great that necessarily doesn't, and then you may have someone that's kind of a little more older and has a lot more of the chronic, and they end up doing very well.
Yeah.
So I think it's not, an indication.
I generally, one trend I have noticed after doing a lot of these cases is older patients get better faster, probably because they have more bad tissue, and as soon as it comes out, they feel better. Younger patients take a little longer, they get more of a robust inflammation process after the procedure and probably heal the injury and feel better after the healing's complete, not just from removing the bad tissue. And the older patients tend to be lower demand too, and so they're going back to less activity, stressing it less. And actually, I would say in all comers, for like if I just take tennis elbow as an example, older patients tend to do better than younger patients in my practice, and probably because their activity goals are a little less than some of the real high-level athletes we might see that are professionals in their sports or going back to a very demanding sport. But they still do well too, but the older folks tend to get better faster and just think it's magical.
I personally, I try to refrain from doing that just because I'd like to leave that person with kind of one good working arm to do things with their activities of daily living. You know, kind of hard if you're sore with both elbows, and so I try to refrain from doing that.
Yeah, and I think most people do for the same reasons. Bilateral surgery is generally steered away from for all those reasons, even though most people do great, and you probably could. I have in select instances, but we're talking probably less than 1 or 2% of the time. Has to be a pretty special situation for that to really make sense.
So to determine whether a patient is a candidate for Tenex, again, it's, you know, you have to properly diagnose that patient with the specific tendonitis or tendinopathy. So again, it's a clinical diagnosis. So just, you know, history, examining the patient is enough to kind of give us a diagnosis. So there's nothing specific that needs to be done, or MRIs, again, not necessarily needed to diagnose, you know, tendonitis, tendinopathies. So definitely it's more of like coming into the office, you know, being able to talk with the patient and getting a history and doing a good exam on them.
Yeah, I'd agree with that, and just office consultation, and there's always individual factors to consider. So we always like to talk about those with you before we plan on this. Just like any, you know, procedure or surgery you would have, you want to kind of know what to expect in your individual situation so that we can tailor that care towards you. I've had a few of those patients.
I've had a few too, yeah.
And yeah, so just like Tenex doesn't work on everybody, and I need to refer to a hand surgeon to do the open tennis elbow procedure, they refer to me after their procedures fail sometimes. And yeah, it kind of goes both ways, and the success rates drop a little bit if you've already failed other major interventions like that. But still, they've done remarkably well, better than I've thought, especially if the surgeries were done 20 years ago or 10 years ago. Because a lot of times scar tissue can develop at the surgical site, and this is a kind of just a new way of doing this.
So this procedure is not good for frozen shoulder. Frozen shoulder is a completely different, you know, entity. It's not related to tendonitis or tendinopathy. That's more when the shoulder joint, the tissue around it, or what we call the capsule, gets really tight. So this procedure is not, you know, good for treating that for that reason, because it's frozen shoulder is not a tendon issue ultimately.
But there is a very easy office procedure that we do. I think both of us do it,
Yes.
where we inject in the office under ultrasound, and then we inject a lot of saline in the joint to distend it. And that too is kind of the new way of treating that, instead of undergoing manipulation under anesthesia as a first option, or capsular release as a surgery. And I'd say 80 to 90% of the patients I'm treating for that, we see a pretty high number of those,
yeah.
Do very well with that simple in-office procedure, and there's virtually no downtime from that. We think it's pretty good, and I'll speak to that just because I think I just recently reviewed all the new studies out there, and it's very encouraging data, and you may have seen on the slides that they've been able to follow patients out now 2 and 3 years, and I've been doing it for 5 years, I think you as well, and definitely that's something that lines up. Our clinical practice and the studies show that if you get better, if you're in that group that gets better, it seems to work. And I've had less than 2% of people, I'd say, who do really well clinically deteriorate significantly, maybe with the exception of the hip. The hip can be a little bit more likely to want to do that. But those other body parts we're talking about, it seems to be a cure, not just a long-term Band-Aid. So the rotator cuff is a group of 4 tendons, and so they're kind of synonymous. But again, with the rotator cuff, that is maybe the one exception to all of this, where MRIs can be very useful in a lot of instances to know exactly what type of injury is in the rotator cuff. And there's a lot of other contributing variables. Sometimes the better decision with the rotator cuff is an arthroscopic surgery to debride the bony bridge that overlies the rotator cuff that can contribute to so much pathology as well. As it stands right now, we're not able to remove those bone spurs that dig into the cuff. And so those are very case by case. Unless it's calcific tendonitis, or unless your shoulder specialist has said, I don't want to operate, but you failed everything else. I have treated a few patients with just standard rotator cuff tendinopathy who've been told that, or they can't undergo general anesthesia, and they've done pretty well. But it's not considered standard of care, I'd say, for most traditional rotator cuff problems yet. But that might change, and I think all it's going to take is a study, and I think there's going to be a subset of those rotator cuff problems, probably a pretty large one, where this really ends up being a great treatment. We're just not quite there yet to confidently recommend that on 90% of rotator cuff problems.
So people say bursitis of the hip. It's kind of a misnomer. So a lot of what people are diagnosing as bursitis is truly the underlying issue is actually a tendinopathy. So that's where kind of the key is of making sure you have the right diagnosis to give recommendations for the right treatment. So it's good to get the patient in the office, do a good exam on them, because a lot of times when patients think they have bursitis, it truly is tendonitis. And in that case, that person is a good candidate for the Tenex procedure.
And I'd only say there's a few examples where it's really bursitis, and those are usually people with underlying rheumatologic disorders like rheumatoid arthritis or lupus. And again, we both do ultrasound-guided treatments. And I will drain bursas occasionally when they really swell up, and we give cortisone directly into the bursa then. But 98% of the time when people have pain on the side of their hip, it's this darn gluteus medius tendon that's the problem. Even when there is some bursitis, the swelling is coming from the tendon collecting in the bursa. And so that's been one of those paradigm shifts, really, that people have talked a lot more about in the last 5 years or so, where what we used to call trochanteric bursitis, I mean, really 98% of the time is probably that gluteus medius tendon and needs to be treated as such. But it is just a harder problem to treat for various reasons. And when people come in to us and consult with us on that, we both take time to go through their individual case and describe what their individual variables might be with that.
Yeah, I find that patients sometimes have a lot of just different things going on that kind of cause that tendon to get irritated or whatever, and that may not be the underlying issue. That may be something else kind of going on to cause that. So you have to kind of weed through some of that and make sure you are picking the right patient for that Tenex procedure.
Yes, it can. That is a very difficult problem. I always feel bad for those patients because they've oftentimes been told there's not many good options for that unless it's a complete tear, and it can hurt a lot and really affect people's lives. It is one of the harder tendons to treat, and somebody's body habitus has to be amenable to it. These probes are only this long, And most hamstring tendinopathies that are referred to my clinic, I've been able to treat with it if it's indicated. The success rates are a little lower than some of the other tendons, but that or PRP are really your only two viable treatment options if you've failed, everything else that we've talked about. The surgeons don't like to go in and operate on those unless it's a real high-grade retracted tear.
Yeah, so there definitely is. One of the treatment options that we talked about was, physical therapy. Learning some exercises that can definitely be done at home. A lot of times if my patients want to go that route and don't necessarily want to go to therapy, I'll encourage them to at least go to one visit, get some exercises they can do to target those specific muscles and tendons, and do them at home for sure.
And do you recommend hard plastic bands for tennis elbow?
Hard plastic bands?
So I assume
sure.
maybe someone's asking like maybe the strap. We do recommend, the tennis elbow strap at times, but much more than that I don't really recommend braces or anything like that.
Yeah, there's a band that goes around here called a counterforce strap, and that might be what they're referencing. And it changes the tension on that tendon. I've really found, I hardly ever prescribe them, honestly, unless you're a tennis player or a pickleball player or it bothers you with a particular sport. And on your lead arm in golf, actually you see just as many golfers get tennis elbow, interestingly. That's another place. So if it's a racket sport or golf, while you're playing that sport, it can have some effect, but just walking around wearing it day to day, I've never found does really anything, and most patients don't like wearing it, and it's hot and sweaty, and they prefer to have it off. So I only recommend it if it's real activity-related pain with one of those activities.